Hey, Margie here. I get asked all the time about supplements, and people are so confused. Well, we're going to clear that up, and you will learn what are the most important supplements for osteoporosis, what forms should you be taking, how much, and what are they really doing. So, this is packed with amazing information, and I invited Dr. Kim Millman to join me because she has so much information and has worked as an integrated medicine physician for over 15 years with people with osteoporosis and bone loss and has had such great results. And I just felt she would really be the right person to shed light on this topic. So, a little bit more about Dr. Millman. She's a Stanford, UCSF, USC trained integrated medicine physician and research scientist. And she sees patients individually and teaches an online program called Restore and Rebuild 100 Days to Healthier Bones that I also teach 2 classes in. And the two of us together founded the Bone Health Academy, where we teach a practitioner program. So she is just full of so much information, and you'll really understand supplements after this. So stay tuned. Welcome, Dr. Millman. I'm so happy to be here with you.
Well, thank you. It's a pleasure.
You know, this is so important because people are really confused when it comes to supplements. What works? What should I take? There's so much confusion. What form? So, we're going to clear that up today. And you've been doing this for over 15 years and had such success with your patients. And I think there's nobody better who can explain this and why you're choosing the certain supplements that you're choosing. So, we're not going to go over everything, but we're going to go over the key ones. So, I'm so excited that you're here with me. And why don't you get started?
Yeah, of course, I get this question all the time. You want to absolutely get the basics right. You don't want to be taking the wrong form of calcium or magnesium. So, absolutely, you got to start with the basics. And the basic minerals are calcium, magnesium, and I'm going to put zinc in there. I also like boron and potassium, but I'm going to go into some details on calcium, magnesium, and zinc and for the interest of time. So basically, in general, for your minerals, you do not want to be taking a mineral that is an oxide or a carbonate because they are like rocks. They absorb poorly. They take a bunch of hydrochloric acid to break them down, and they also can cause constipation. So those that are better absorbed are what is called a chelate. So a chelate is a mineral that has a amino acid or a modified amino acid that is complex to the mineral. It makes it highly absorbable, and you don't get GI upsets from them. So the big ones are the big chelates are like dimalate, bisglycinate, aspartate, threonate, and citrate. And so these are the good forms of minerals. So just keep that in mind when you go and you look at a product and you want to look at the ingredients, you want to see what forms these minerals are at. So let's take a deep dive into calcium because there's a lot of details about calcium that we want to really stress. So first of all, what are the good forms? I like dimalate and citrate. And so there are two products. One is from Designs for Health. Both of them are actually. One is called CalMag 2 to 1, and this has calcium and magnesium dimalate. And then there's Osteoben. Osteoben has calcium, magnesium, zinc, and genistein. And we're going to talk about genistein a little bit later. Okay, how much to take at the same time? I can't tell you how many times I have patients come in and they're taking 1,000 milligrams of calcium in a big horse pill and they're taking it all together. And we know from the fractional absorption of calcium that the more you take at once, the less percentage you absorb. So 390 milligrams is about the sweet spot where your fractional absorption is the highest. And if you take more than that at the same time, basically you're taking in more, but you're not absorbing more. So you're literally pooping the rest of it out. And and that is also very constipating. Then how much to take? And I've done a lot of research on this. And one of the things that you have to consider when thinking about how much calcium to take is something called the calcium paradox. And this is that your bones can be completely depleted of calcium, not completely depleted, but depleted of calcium. And at the same time, you can have too much calcium in your arteries, causing plaque. And we know this because we can see this in a coronary artery calcium scan, that the calcium is there in the arteries. And so we have to be careful of how much calcium we take. In fact, there was a landmark study that went out that showed that that too much calcium, either dietary or supplemental, can lead to a 15% increase in heart disease. So we want to be very careful when we take calcium. Calcium metabolism is complicated, and we want to respect the body. So because of that study, I recommend somewhere between 800 to 1,000 milligrams. And that includes both dietary and supplemental calcium per day. And I recommend that people actually do a count of how much dietary calcium they get with a free app called Chronometer. And so you also want to know what your levels of calcium are in your bloodstream. If you have too low of an amount, so this would be like 8.8 to 9.1. So if your calcium is too low, what's going to happen is your parathyroid glands are going to get hyperactive, and your parathyroid glands are going to start stealing the calcium from your bones. So you don't want that to happen. You want to have your dietary and your supplemental calcium high enough so that your levels stay normal. So that might mean that you go a little bit above 1,000 milligrams in diet and supplement. It just means that you potentially have a malabsorption problem. And then if the calcium levels are over 10 or 10 or over, then this is too high, and that could be an indication that there's a problem with the parathyroid gland. So you want to look at all these things, and this is kind of how you nuance what calcium you take, how much you take it at one time, and how much you take, and what your levels should be.
It's so interesting because that's what I see all the time for so many years, that people think more is better. And, for years, the milk mustache, and it's just this calcium issue is just something that's been propagated. So I'm so glad that you shed some light on that.
Well, in fact, the RDA for calcium, this is what doctors are telling their patients to do. The RDA for a woman over 50 is 1,200 milligrams. So, that's what they're being told to take 1,200 milligrams per day of supplemental calcium, irregardless of what their dietary calcium needs are. And they don't seem to understand the calcium paradox. They really don't.
A question I get about calcium all the time is that when people have a coronary artery calcium score that's abnormal, they wonder, should they just stop their calcium?
Yeah, I get this question all the time as well. And a coronary artery calcium score that is above 0 is abnormal. But there is a gray area as to what is considered mild, moderate, and severe. And really, it doesn't matter, because I have a case that I want to bring up that's very illustrative. So I had a patient, and she had a coronary artery calcium score that was above 0, and she decided to stop her calcium supplements and have a diet that was low in calcium. And what happened was that her serum calcium dropped down to 8.8, which is low. Anything below 9.2 is low. And exactly what you would expect happened, which is that the parathyroid glands became more active, and her parathyroid hormone went up by 20 points. And this is an indication that the body is trying to compensate by stealing the calcium from the bones. So you absolutely have to strike a balance, and you need to keep your calcium levels in your blood between 9.2 and 9.9. And I say that I still like my recommendation that you should be taking supplementation and diet, that your calcium intake should be somewhere between 800 milligrams and 1,000 milligrams. It's already incorporating the fact that there is a calcium paradox, and we're being extremely safe with this recommendation. So don't stop your calcium supplements, and don't have a low diet that's in calcium. If you have a coronary artery calcium score above 0, is my recommendation to my patients.
Hey, Margie here. High quality supplements are a big part of a comprehensive osteoporosis program. To help you, I offer a significant discount every day in my supplement store through FullScript. FullScript has the most extensive catalog of professional grade supplements and wellness products I've ever found. So all you need to do is go to tinyurl.com. That's tinyurl.com/supplements for less. And you'll get to my FullScript store, and in there, you'll see my favorite bone building supplements. So make sure to check it out, and the link will also be in the show notes. So let's get back to the show. Okay, so we cleared that one up. So let's continue. Okay, continue with your, so we've gone through calcium. Let's continue because the other ones are so important as well.
Yeah, so let's continue with minerals. So for magnesium, the bad forms of magnesium are the oxides, so stay away from them. And so there are some differentiating types of magnesium that you want to know about. So if you're having problems with bowel irregularity, or you're not pooping enough, magnesium citrate is a good form to get your bowels moving. It's the one that has the most GI effects. And then L-threonate, magnesium L-threonate, is very good for sleeping and to have a calm mood. And I usually have my patients take L-threonate at bedtime. So that's a good one. I love to add magnesium L-threonate at night. And then for muscle support, bisglycinate is a good one as well. And of course, I like dimalate for bone support. And so you really want to have enough magnesium. And when you look at the amount of magnesium that you need at least 1/2 of the number of milligrams of magnesium compared to calcium, and even higher than that. So 1/2 to like a calcium 2:1 magnesium, or a calcium 1:1 magnesium are really good ranges. We know that magnesium is so important. It helps you to absorb more calcium. It activates vitamin D. It dilates your arteries, and it supports your muscles. So you want to make sure to have enough magnesium. And again, my favorite ones are CalMag 2:1 and then Osteoben. And then just to complete the minerals, I love zinc. Zinc is so important for the bones. It increases your bone building, and it decreases your bone breakdown. Not only is zinc important for the bones, but it's very important for immunity and blood sugar stability. And it's really helpful for raising testosterone levels. So from my point of view, I like doses around 20 to 30 milligrams per day. And I like the chelated forms, like the bisglycinates, the arginate glycinate forms. And so I like people to be taking zinc for their bones and for their immunity and blood sugar.
I just wanted to chime in for a second, back to the magnesium, because I have seen, we haven't really talked about this, but so many companies will have like a mixture of magnesium where you see different types. And then when you see, or I've even seen where it says, magnesium citrate on the outside, but when you look at the composition, the majority is oxide because it's so much cheaper. So I think people have to really be careful. Don't just look at the front of the bottle. Also look at the back because I've seen this time and time again. And I've even been fooled with it where all of a sudden I'm like, oh my gosh, this is magnesium oxide. So they throw it in. So be really careful.
And I would say a small amount of magnesium oxide isn't really a big deal, but yeah, you don't want the predominant form to be oxide. And if you can get just a pure dimalate, especially for your bones, I think that's best. Okay, so you want to move to the fat-soluble vitamins like vitamin D and vitamin K. I like vitamin D blood levels to be somewhere between 40 and 55 nanograms per mil, and even up to 80 nanograms per mil. I like 50 to 55 because that's where parathyroid hormone plateaus. So when vitamin D is very low, like in the teens and the 20s, absolute vitamin D deficiency, parathyroid hormone is high because it wants to bring in more calcium because that's one of vitamin D's jobs. So it sort of takes over. We don't want parathyroid hormone to be high. So parathyroid hormone comes down as vitamin D rises, and we want PTH to be plateaued, and that happens around 50 to 55 nanograms per mil. And we have a big study that was done in 2020 that shows that at a vitamin D level of 55 nanograms per mil, that the mortality from COVID was essentially zero. So we know that we want vitamin D to be performing at its best for immunity and for calcium metabolism. And that's why I like that sweet spot of 50 to 55 nanograms per mil. And if it goes up to 80, that's okay. If it goes higher than 80, then that's just too high in my mind. And so, but you want to optimize this level. And so vitamin D metabolism and vitamin D doses should reflect your personal characteristics and the season of the year and where you live. So you need more vitamin D if you're getting less sun, if it's in the winter months, if you have a higher weight or higher body fat, if you have darker skin pigmentation, and if you're in the northern latitudes, in the northern hemisphere. So in Boston, you're going to make less vitamin D than here in San Jose or San Diego. And so you need to take that into account. So there's a range. And so people should be measuring their vitamin D at least once a year, maybe twice a year. And so for the patients my patients who typically have osteoporosis, I'm looking at doses in the summer of about 1,000 to 3,000, and in the winter somewhere between 3,000 and 8,000 IUs per day. And then we come to my favorite vitamin and mineral for bone health, and that's vitamin K. And the reason why is because there's so much data on improvement of fracture risk with 15 milligrams of MK4 3 times a day. And I've been doing this in my practice now for 15 years, and my patients don't fracture. Of course, I have a few patients who have fractured, but in over 600 cases, there's 2 or 3 people who have fractured. So I have a very, very good success rate. And I think a bit of that is from recommending to my patients a high dose MK4 15 milligrams 3 times a day. However, I did a lot of research this last summer on vitamin K and vascular calcifications because, we want to acknowledge the fact that vitamin K is involved in the calcium paradox. And so vitamin K helps to bring calcium from the arteries and shuttle it into the bones. So we theoretically, and it does so by carboxylation of osteocalcin and GLA matrix protein. And so theoretically, vitamin K might be able to reverse vascular calcification. So I did a lot of research on that. And one thing that I found, to my surprise, is that taking more MK4 than 5 milligrams doesn't really improve the carboxylation of osteocalcin. So I refined my recommendation of not taking 15 milligrams of MK4, but taking only 5 milligrams at a time of MK4. And then when I was looking at the vascular calcification data, the results were mixed. So what I found was that in some studies, vitamin K was able to reverse vascular calcification or even slow the progression down. And in other studies, it didn't matter. It had a null effect. And what they were using in these vascular calcification studies were either vitamin K1 or they were using MK7. There were no studies using MK4. And so, because theoretically, vitamin K should be able to reverse vascular calcifications or halt the progression or slow down the progression, um, I recommend now a mixture of vitamin K1, MK7 for the vascular calcification effects, and MK4 because of the improvement in fracture risk that is within the studies is shown to be the best with MK4. So my recommendation now is Thorne's vitamin K, and it has 1 milligram of K1 and 5 milligrams of MK4 and 90 micrograms of MK7. So this has all your bases covered. So you've got the potential to improve fracture risk with MK4. You've got the potential to reduce vascular calcifications with MK7 and vitamin K1. And also, MK7 has a much longer half-life, so you don't have to take this 3 times a day, but I do recommend taking it twice a day. So that's my new recommendation on vitamin K1, and it's born from, looking at the compilation of both of these sets of data.
No, it's interesting because when I talk to people, that is the one thing, and I don't know why there's such good research on it, and it's used in Japan. I just can't imagine, but it's the one thing that most doctors are not recommending. They'll recommend calcium and vitamin D, and that really is it. And it's just so surprising to me that that vitamin K2 is just not right up there with everybody. So I'm so glad you brought this up because I think it's absolutely essential and then everybody needs to be on it and maybe things would be different, because it does help shuttle the calcium into the bones and out of the soft tissue. So it's just so important.
Yeah, and the other point to be made is that there's so much data on safety of vitamin K. There are studies that have looked at whether or not there's increased risk of heart attacks and strokes, and there are not, and whether there are increased risks of blood clots in the legs and in the lungs, and there are not. Now I'm very careful when a patient has a blood clotting issue where there's a known issue because we don't have any study data on that group of people. So those are the people who should be careful of vitamin K. Theoretically, it shouldn't matter, it shouldn't increase the clotting factors, but I think that we just don't know in that group of people. So that would be my one concern. And we used to people who were on blood thinners, when people were on Coumadin or warfarin, and that was a vitamin K antagonist. Of course, you couldn't give high dose vitamin K with that. But that blood thinner is very rarely used now. And blood thinners like Eliquis and Plavix, they're not vitamin K dependent. So, but if someone is on a blood thinner, that would be something you would absolutely want to talk to your doctor. Of course, in this presentation, all of any kind of supplement that you start should be reviewed with your doctor because only your doctor knows your medical history. So, but there's a lot of safety with vitamin K. Okay, so let's move on to one of my other top supplements, and that is genistein. And so it is a phytoestrogen, which means it's a plant that acts and mimics estrogen. It does not raise estrogen levels, but it attaches to the estrogen receptor and it acts estrogenic. And so there was a study where it was a head-to-head trial of genistein a glycone at 54 milligrams compared to Fosamax. And they looked at different parameters. They looked at the increase in bone mineral density between these two at 1 and at 2 years. And there was no difference in the increase in BMD for either of these. So this means that potentially what this means is that genistein is working as well as Fosamax at increasing bone mineral density. And the other thing that we saw was that it does so by decreasing the bone breakdown. And we can see that as evidenced by the decrease in C-telopeptide or CTX. And so the decrease in CTX was just as good as it was with Fosamax. And then to our surprise, it had a secondary mechanism that Fosamax doesn't have, which is to decrease sclerostin. And sclerostin is a brake on bone formation. So if you take the brake away, you're allowing the bones to form better. And this is the mechanism by which Evenity works, an anabolic. And so there was an additional benefit of genistein in that it decreased sclerostin. What they found was that the best improvement of BMD was seen at 2 years. So it does take some time to work, and so it does take some commitment. But I have a lot of my patients on genistein now, and Osteoben has calcium, magnesium, zinc, a little bit of vitamin D, and genistein in the proper aglycone form, and it is not coming from soy. So people who have problems with soy, maybe a sensitivity to it, can take the Osteoben without a problem. So now let's come to, this is a question I get all the time. Okay, so what about taking genistein if you have a history of breast cancer? So what I would say is that this is a gray area. It's a phytoestrogen, which means that it mimics estrogen. It binds to the estrogen receptor beta. That specific receptor is not involved as much in proliferation of tissues like the estrogen receptor alpha is. So it's safer from that perspective, and then it's a weak estrogen. So it's not going to have as big of an effect as estradiol. It's going to be safer than estradiol, but whether your oncology or your primary care or your healthcare team thinks that that is safe enough for you with your history, it has to be a really considerate. It has to be a very thoughtful discussion among your team. So I can't answer that, but in my practice, what I've found is that I have a couple of patients who were working with integrated oncologists, and they two people in particular, the integrative oncologist has said yes to genistein when I have one patient with a history of breast cancer and one patient with a history of uterine cancer. And so they're both on genistein, but it was not my decision to make. It was everyone's decision to make. And so then and then another very smart question that I get is I'm on raloxifene, and that's what's called a SERM, selective estrogen receptor modulator, that works exactly the same way as genistein does. So when I'm talking about doing combinations of things, I'm always looking for the mechanisms to be different. And if they're not, it's usually because the thing is redundant with whatever you're doing. So it would be redundant with raloxifene. And for the same reason, if somebody's on bioidentical hormone replacement therapy, they're already on estradiol, which is the genistein is likely going to compete with the estradiol, and so it again is redundant. But for people who actually don't want to go on bioidentical hormone replacements, they want some hormone support. Genistein is really it's a really great idea for these people.
Okay. So let's continue.
Okay, so so my last like top supplement and you got to get these basics in, and that is protein. So I know that many of my postmenopausal patients suffer from sarcopenia. And what is this? This is muscle loss. And one of the reasons that women can have muscle loss in the elderly in their older years is from inadequate protein, especially among vegans, vegetarians. Often women are not getting enough protein in their diet. And so Perfect Aminos is an amino acid blend, and it's a protein supplement. It is my favorite protein supplement for the reasons that it's composed of amino acids, which are the building blocks of protein. And these amino acids are stacked in their composition are such that the the amino acids that are the least found in food, they're called the bottleneck amino acids, are what is found in the highest percentage in Perfect Amino. This means that it's very efficient in building protein in the body with minimal waste. It doesn't break a fast. It's vegan. And I've had such good success with Perfect Aminos. I've had people who have said their back pain is much better, that their muscle mass is better, their sarcopenia is going away, and that people are feeling better overall. And that they can only take like a few months to really see some improvements. And you really need to have enough protein to fuel your muscles. And without it's sufficient rebuilding is really not possible. So it's very, very important to have a good protein source. So that's it for my top supplements. Of course, there are a lot more, but you got to get the basics right, and this is some of the this is some of what I talk about all the time.
Okay. And personally, I take these supplements myself. So these are all really great recommendations. And it makes such a difference. That's what's really good to know. It's not like, it really does. So we believe in food, but also when necessary, the appropriate supplements. So I can't thank you enough. And I think that we have to share a few things though, because I just wanted to share with everybody. We have a couple things coming up. Dr. Millman runs a course that I feel so responsible because years ago after my summit, everyone's writing to me. I want to see Dr. Millman. I want to see Dr. Millman, but she see patients all over? And no, the answer is, well, why don't you can tell them in a minute how you see patients because you can see her. Well, you'll explain. But so I said, Dr. Millman, if there was a way that you could create a course, and and she did, and I actually teach some of the two of the classes. So why don't you tell people about how you can see people one-on-one, and then about your phenomenal R&R course?
Yeah, so I do see patients one-on-one in my virtually or in my clinic in Los Gatos, California, but I can only see patients who are California residents. So, so the, unfortunately, there were the demand was so high, because there my practice is pretty unique. A functional medicine doctor who has a lot of experience with osteoporosis and this great track record, and I have a unique protocol and way of practicing. And, Margie talked me into building this course so that it's the next best thing to actually seeing me in clinic. And I teach people these functional medicine concepts and how to evaluate their root cause of bone thinning by doing testing and how to interpret the tests and then what my protocols are for helping to mitigate those root causes. And I've been teaching the course now for 3 years. We've had actually incredible success. We just got another testimonial just this last week who sent both Margie and I an email that was like, I now have DEXA improvements for 2 years in a row. I've learned everything from Dr. Millman and from Margie, and I can't thank you enough. And I mean, so we're seeing real bone mineral density improvements. We're seeing people's CTX, the C-telopeptide, the bone breakdown marker, go down by half in some of these people. So it's been super rewarding for me, and I love teaching it. And so we're opening up registration for the brand new cohort, which starts March 7th. And the it so the March 7th is a Saturday. That's kind of confusing people. That's the day that the first content goes live. And then every Thursday, we have a live Q&A, except for during integration weeks. About every 4 weeks, we have an integration week where there's no content and there's no live Q&A. So there's 10 weeks of live content, and then there's 10 weeks of live Q&As. And there's all kinds of resources, handouts, progress trackers. Just I've worked really hard in having these accessory materials for you to work through. And the Q&As are really, really they're empowering. We have this great community, and they're people love them. And so the registration closes on March 7th. It is $797. And then Margie has a special coupon that gets you $100 off. And her coupon is happy and then S26 100. So use that coupon for sure to get yourself $100 off. So that brings it from $797 down to $697. We absolutely want to see you there and want to support you, in this really important part of your life.
And that's the early bird special, which is significantly less than the actual price.
It's $400 less, and it's somewhere around February, maybe the end of February, where early bird goes away. So
Anyway,
you
great
want to sign
opportunity.
up now.
Yeah, if this interests you and you really want to learn what happens, what happens is everyone becomes really knowledgeable. So then when you go into your doctor, you understand the testing, you understand, and you really can become an active participant in your health. And that's what we love. We love empowerment, and that people feel good, confident, know what they, and then really understand, because knowledge is power. So anyway, so that's number one. So if you're interested, we'll have all the links also in the show notes, and it goes twice a year. So if you can come this time, it will be around again in the future. But it's not going away because it's been so great. And I have to tell you, every person, so many people in my community have done this, and they just thank me so much, because it's just a great way to really make sure you're on the right track and keep going. So that's number one. Number two, if there are any practitioners, I think you've heard me talk about this before, but if there are any practitioners, if any of you are practitioners or you're working with practitioners, Dr. Millman, where I convinced her to do this course, she convinced me to join forces. So we started we started in October our first certified integrative bone health practitioner program through the Bone Health Academy that we co-founded, and it's been absolutely amazing. And I'll have that information in the show notes because we're training people because we want to spread this information. It works. It's so exciting. And we can't do it. And we want other people who are there, who are working with clients, who want to really learn about bone health and really spread all this information. So we've had such an amazing first cohort, and we're starting another one in May. And we only take 30 people. So if there's anybody, because we really spend time with them and we really want them to learn. And anyway, so you can learn more. I'll have that information in the show notes as well.
And you know what happened too was that that was born out of necessity as well, because what was happening was that, people who were taking R&R, some people were really could do it all on their own, or they had enough support from their doctors, but there was a fair number of people. We have almost 10 people who are really looking for practitioners to work with and are asking us, are your practitioners graduated yet? We want to work with them. So, we really are trying to have a huge ripple effect in this community, and so training practitioners is the way to have the biggest ripple effect we possibly could.
And the good news is it's like spreading good things because, as I always say, a diagnosis of osteoporosis is an opportunity to look at your life, see what areas can be improved. And then when you do, everything gets better. So when we know this is possible, we want to share it with as many people as possible and train as many people as possible to work. So if you, again, are a practitioner and this interests you, just yeah, I'll put a link also in the show notes where with the email. You can also just email me if you have questions. We'll have the information so you can really see what it's about and all the details.
Yeah, and it's simple. It's at thebonehealthacademy.com.
Yeah, that's all you have to do. TheBoneHealthAcademy.com. But anyway, well, thank you so much. Is there anything you want to add before we end? This has been so helpful, and it really clears up about supplements. And there's more, but this gives people the basics, like where to start and what are the absolute key things, which I think is just so important.
Yeah, I guess I would just end by, saying that, just these little tweaks in your supplements can really make a big difference, like how much calcium to take, what calcium to take. These are tiny little tweaks, but they do really make a big difference. And it is important that you understand these concepts. So I think it's really, really valuable information.
Absolutely. Well, thank you so much. It's always a pleasure, and we see each other all the time now. So I'm just glad that we can share this with everybody. So thanks so much.
You're welcome.
I hope you enjoyed my interview with Dr. Millman and now have some more information on supplements that you can put into your life. All the links to the programs Dr. Millman talked about will be in the show notes. So thank you so much for tuning in, and I look forward to seeing you on the next episode.